Hello, I'm Denise Connelly from the University of Western Ontario School of Physical Therapy. Thank you for this opportunity to provide a summary of our project entitled Virtual Care Planning with Residents and Families of Long-Term Care Homes During COVID-19. I'm joined in this presentation by two registered practical nurses, RPNs, who hold leadership roles as RPN champions in the two long-term care homes collaborating on this research project. As RPN champions, they have led the project on site at their respective long-term care homes, engaging residents and family in stages of the research, leading PIECES trained RPNs to use our intervention during care planning for residents, and contributing to development of research resources during the study. This project is funded from fall 2020 to March 2023. Please note inclusion of this disclaimer in our presentation. This research study is one of 22 implementation science teams from across Canada, awarded funded by Healthcare Excellence Canada in the Strengthening Pandemic Preparedness in Long-Term Care competition. This research is a component of the Long-Term Care Plus Acting on Pandemic Learning Together initiative. Long-Term Care Plus is a community of long-term care and retirement homes that are working together to strengthen an ongoing pandemic response. As long-term care and retirement homes continue to adapt to COVID-19, collaborative learning is needed more than ever. The goal of the implementation science teams is to deliver knowledge from research to assist long-term care home and retirement homes in rapid change, to navigate challenges and opportunities, and to enhance organizational skills and resilience. Here at the University of Western Ontario, we are one of 18 host institutions across Canada with research occurring in 91 long-term care and retirement homes. Working in partnership with WeRPN, the Registered Practical Nurses Association of Ontario, PIECES Canada, and the Canadian Gerontological Nurses Association has been an immense opportunity. Further, our research is completed in collaboration with two local long-term care homes, Vision 74 and Copper Terrace. Our research team consists of 19 team members, including academic researchers, registered practical nurses, and administrative leaders from our partner long-term care homes, WeRPN, and PIECES Canada. Further, our partnership includes graduate and undergraduate research trainees, residents, and family care partners of long-term care homes. Each team member has been engaged in the research design, planning, and implementation and preparation of findings for dissemination. This presentation will highlight experiences of a multidisciplinary, multi-sector partnership, innovating virtual team-based care planning for residents of long-term care homes, employing implementation science methods. Implementation science is a study of the methods and strategies that facilitate uptake of evidence-based practice and research into regular use by practitioners and policymakers. We needed to understand implementation of change in a crisis to improve our response to crises, to address sustainability of the implementation, and to explore feasibility of the spread of the intervention. In our study, we joined PIECES with the Consolidated Framework for Implementation Research, or CFIR. The PIECES program, Putting the Pieces Together, represents an acronym where the letters P, I, E reflect an individual's physical, intellectual, and emotional health. The letter C focuses on maximizing the capabilities of an individual to support quality of life. The final letters E, S integrate the living environment of a person and the social being encompassing a person's beliefs, culture, and life story. These 5 elements, pieces, are the cornerstones of the philosophy and care of the pieces approach. Pieces began in 1997, initially in long-term care, in recognition of the need for a system-wide approach to the understanding of and care for the complex and at-risk older person. It is a holistic person and care partner directed approach, anchored in performance improvement and designed to enhance capacity. The field of implementation science seeks to systematically close the gap between what we know and what we do, or the know-do gap, by identifying and addressing the barriers that slow or halt the uptake of proven health interventions and evidence-based practices. One of the unintended effects of COVID-19 lockdowns put in place to protect older adults from COVID infection was the awareness of the detrimental effects of social isolation experienced by older adults with cognitive decline living in long-term care homes. An acute need for resident care planning was revealed and underscored the necessity of virtual presence. Pieces delivered in a virtual platform offers solution-finding framework for care plans. Implementing Pieces embedded RPNs at the bedside in team practices such as decision-making and instilled empowerment to initiate care. Further, RPNs needed teamwork to remain resilient during the COVID pandemic. This study addressed 3 promising practices, that is, people in the workforce, presence of family, and planning for COVID and non-COVID care. Following the theoretically informed implementation science method of the CIFR model to support the engagement of stakeholders in the research process from inception to inform sustainability and uptake of healthcare innovations, and to learn firsthand the impact of enacted strategies and interventions on residents and their family care partners, organizational process, and nursing practices. Stakeholders in this study included RPNs, residents, families, Pieces Canada, We RPN Professional Association, and administration or leaders or directors of care. This figure provides an overview of the Consolidated Framework for Implementation, or CIFR. CIFR is a pragmatic structure used to guide implementation science research and identify critical pieces as to what works where and why across multiple contexts. This framework is being used in our project to highlight key constructs and how they affect the implementation of the Pieces approach. There are 5 main domains to address through the implementation, including characteristics of the intervention, inner setting, outer setting, individuals involved, and implementation process. Elements of our research that map to these 5 domains will be presented in the subsequent slides. In these next few slides, we will unpack the CIFR model as it relates in particular to our study. The first component is characteristics of the intervention. Pieces is a holistic clinical assessment framework intended for use by interdisciplinary teams to respond to the complex health needs of older persons. Central to the Pieces approach is the 3-question template. 1, what are the priority concerns? Is it a change for the person? 2, what are the risks and possible contributing factors? 3, what are the actions? For this project, Pieces was adapted to be delivered using video conferencing technology. The goal is to include family care partners in care planning for residents virtually to work within the constraints of the lockdowns. The Pieces intervention is delivered in partnership with Pieces Canada Associates, who provide Pieces training to 5 RPNs at each long-term care partner, and ongoing coaching and mentorship with implementation of the virtual Pieces. In a distributed leadership model, funding was shared with our long-term care home partners in a lump sum to cover costs associated with Pieces training, purchase, and installation of technology, including iPads, TVs, and Wi-Fi. Staff replacement during data collection was also part of the budget. The second component, inner setting, first requires us to describe our two long-term care home partners. They are two medium-sized, approximate 100-bed long-term care homes, each in operation for greater than 30 years. Trust is built between long-term care homes and the research team by transferring a budget of the research funding for them to manage the aspects of the research activities needed to be completed within their long-term care home settings. The long-term care home leaders and members of the research team were immediately committed to implement and attend weekly meetings for the past 16 months. Using virtual or video technology in resident care planning was a new experience for the homes. They had an embedded practice and culture for use of the telephone to communicate with family and care partners. The research introduced this new technology. The homes had no previous access to Wi-Fi for video conferencing. Very few residents had tablets. Our partner long-term care homes had to adjust to ever-evolving COVID-19 pandemic restrictions. An ongoing process of pause and restart of the intervention permeated the project, and a sensitivity was needed by the academics on the team to respect and support our long-term care partners in the competing priorities for providing care to residents during the pandemic, while also participating in the research project. The outer setting in the context of our study included Directive 3, under which lockdowns and restrictions to family care partners was implemented. Unintended consequences of these health and safety restrictions included isolation of residents of long-term care with loss of contact and a lack of understanding for the absence of their loved ones. For many older adults, not seeing their family was worse than the risk of death secondary to COVID. Further, with many older adults living with cognitive impairment, they had an inability to understand why their families were not coming to see them, why they had been abandoned, and the loneliness and desolation was inconsolable and often unexplainable to them. The media portrayed the devastation and loss of life in long-term care homes across the country and internationally. COVID-19 placed pressure on the government to better support long-term care homes through incentives. We needed to ensure that our evidence is used to improve resident care going forward. Further, within the domain of outer setting, we identify that implementation of our virtual pieces is supported through the organization of Behavior Supports Ontario, Pieces Canada, WeRPN as the Professional Association of Registered Practical Nurses, and the organization Strategy for Patient-Oriented Research, or SPORE. The fourth domain is individuals involved. Administrators and RPNs at our partner long-term care homes were aware of and open to the potential impacts of pieces in their facilities. The RPN champions felt capable of implementation, having received training, coaching, and ongoing mentorship from the Pieces Canada associates. One associate was assigned to each long-term care home partner. After initial implementation, taking the leap to use video conferencing instead of the telephone, the staff and families are seeing successes with Pieces and have a greater recognition of its value. It seems the Pieces program aligns with values, motivation, and capacity of each long-term care home. A huge benefit being voiced by staff, family, and residents alike is with the video, that you can see each other face to face. This seems greatly appreciated by everyone involved. And with this point, we will hear from our partners involved in implementation science research next. This is Vicky, our family research partner. We asked her, what motivated you to take part in this project?
I recently moved my mom into long-term care. The ability to improve the quality of interaction with the staff there was one of my main motivating factors. The holistic approach to every facet of her well-being was really one of the main reasons. I recently moved my
We asked, what would you like to see about the involvement of family in research going
I
forward?
think it's paramount that a family representative is involved in the research going forward. The ability to garner or get that perspective of a family member or family members, or even residents, right? That is the collaboration that benefits everyone. The holistic approach, again, is invaluable to the care that they're receiving in these long-term care. And I can't speak enough to the benefits of this process, even just in my individual interactions with the staff and with my mom with the staff in our setting. I think it's paramount that recommendations would be that that it continue, possibly even more interaction. Like I'm the lone representative with my mom. Could that be expanded to 2, doing things virtually and having a little bit more input? The ability to meet the team collectively through this virtual process is huge. A phone call doesn't always just, serve its purpose, but being able to see the nuances and the nonverbal aspects is invaluable.
Next, we'll hear from Jackie Ripley, one of my co-presenters and the RPN champion at Copper Terrace. We asked her, what are your experiences being involved in this research project?
I think it's been exciting and something new and different that I haven't been involved in before. It was a lot more work than I expected, I guess. And not so much in the beginning. I think it's just been more recent when we were first implementing it onto the units and the floors and having them do referrals and getting all that organized. But it's settled down a lot again, and it's been a very effective process, I think. I think it's been.
We asked, what have you learned from that implementation process?
More communication and more demonstration would have helped. Just because, as we know, we had a few pieces trained RPMs that didn't want to do it as much. And now that it is being implemented and it's being effective, they're more excited to try. Rather than when before they're just like, no, we don't have time, we can't do it. So I think there's more communication and explaining that we're going to work it all through together and make changes as needed, and then just actually doing it, and they have seen that it's been working and it's been effective and not a burden.
Next, I talked to Melissa Babcock, a co-presenter and our RPN champion from Vision 74, about her involvement in the implementation science process.
I was really, really excited to be part of this research project. I had heard it was about pieces and I had taken the training, so I had some knowledge regarding what pieces was. When I first started the research project, it was really eye-opening to be involved in the implementation science part of it. So I really got to work with the researchers from beginning to end. I was really.
Finally, the 5th domain is the implementation process, and both long-term care homes develop the processes for embedding the pieces approach to address resident responsive behaviors and care planning within the culture, policy, and day-to-day operations of their long-term care homes. Initially, the homes worked separately, and then organically they joined together to collaboratively learn from each other about the how of embedding the pieces approach into a way that would support their work, staff, family, care partners, and residents in a meaningful way. In this slide, we provide a simplified rendition of the care planning algorithms developed by the long-term care partners. Highlights of the process include the new position of RPNs noted in green. Pieces provides opportunity for bedside staff in the referral process to initiate a care planning conference. Family, noted in yellow, are engaged in conversation about the responsive behavior that initiated the care planning process, with the purpose of gaining information to contextualize the responsive behavior. These virtual conversations are supported in a shared solution finding approach, problem solving with the family or care partner versus informing them that the behavior has occurred. Our experience is that this approach reveals opportunity to try non-pharmacological interventions sooner and more often, which may translate to mitigate or reduce the referrals to BSO noted in gray, or involvement and referral to psychiatry. Meaningful partnership engagement was a process of gaining insights from residents and their family or care partners and the staff. It's important to recognize their time and contribution, and gift cards were a tangible example. Contributions sometimes appear small to partners, however, they're extremely valuable to the research team. Sharing their previous experience and ideas and how they would like care planning to look in long-term care helped to inform the PIECES intervention implementation. They have been involved from the very beginning, and regular communication has been key to establish and solidify a group of people who did not know each other at the very beginning into a strong collaborative team. Mutual kindness and respect are pillars of this group. One tangible example is that our requests for partner involvement were paced and sparing to avoid overwhelming them with research tasks and to respect their time when they're in the depths of lockdowns and staff shortages. In conclusion, the goal of our study is to improve care planning processes for residents with behavioral expressions through leadership of RPN champions and the collaboration of families using virtual means of communication. We continue to collect data at both homes. Dissemination of our findings are in process. The next steps are to complete a readiness